Hi guys. So as discussed, I'm going to create these online lectures for you that you can review at your leisure. So this week it's antimicrobials and anti-inflammatories. Our first lecture here is chapters 43 and 44, and it's going to reflect antimicrobials. Okay, so let's get started. So the 5 antimicrobials we're going to focus on for this first part of the lecture are sulfonamides, penicillins, cephalosporins, macrolides, and tetracyclines. Okay, so just some background about infection. So specific designations exist for community-acquired infection. So this is an infection that's acquired by an individual living in the community who has not been hospitalized within the last year or had any sort of medical procedure done to themselves. So that could include dialysis, any sort of surgery, catheterization within the past year. Okay. So sites of origin of infections. Specifically, we all know the infamy surrounding healthcare and the associated infections that go along with healthcare. So these are infections that are contracted in healthcare facilities. They were not present upon admission to the facility, okay? And it has to occur after 48 hours past admission because you could have an incubation period at which point they were admitted with said infection and it just wasn't measurable at that time. So it is one of the top 10 causes of death in Canada. That's specifically hospital-acquired or nosocomial infections, okay? More difficult to treat, mostly because by the time these infective microorganisms come to inhabit these hospital and healthcare facilities, they are quite virulent and resistant to many antimicrobials. It's just the nature of a high concentration of infective agents in places like hospitals and long-term care facilities. Some examples include MRSA or methicillin-resistant Streptococcus aureus. Streptococcus aureus being a normal part of the microbiota of the skin and many other parts of the body. But this specific strain is resistant to a very specific type of antimicrobial agent. And of course, then we have our vancomycin-resistant enterococcus, so that's our VRE. These are previously known as nosocomials, but you'll still hear them referred to that way. So most important thing for healthcare providers to be cognizant of is that to prevent the transmission of these microorganisms from patient to patient or from patient to healthcare provider, it is very important that we perform proper hand washing techniques. We use appropriate antiseptics and disinfectants, and of course, as you have seen in your clinical practice, wear the appropriate personal protective equipment to prevent transmission from patient to patient. Okay? So disinfectants are used to kill specific organisms, only used on non-living objects. So we don't disinfect people, okay? And they're always cidal agents, meaning that they kill the microorganism. Antiseptics are there to inhibit growth. They don't necessarily kill microorganisms, but we do use them exclusively on living tissues because they don't cause any damage to the host. And they are static, meaning that they inhibit growth. They are not cidal, they do not kill necessarily. So some common bacterial morphological shapes, okay? So these are different shapes in which we find bacterium in the environment. I don't expect you to remember specifically which bacteriums are which, obviously, but this is just for your information, okay? So we have a nice cocci, a coccobacilli, a spirillum, and a spirochete, the vibrio, the bacillus, and the fusiform bacillus. So sometimes we're going to hear these terms used, and that's just referring to the morphological shape of the bacterium. Okay, so antibiotics or antimicrobials, as they're more common, well, I should say more specifically known, they're used to treat specifically bacterial infections. And typically we want to administer these agents in suspected areas of infection that have been culturally identified. So we've taken a swab or we've taken a specimen, we've grown it up in culture, and we can specifically isolate which bacterium is responsible for said infection and then use the appropriate agent to treat it. Okay, I'm sure those of you from my clinical group remember that this is the bane of most people's existences because you have a lot of people prescribing antibiotics before any of this is done, which isn't necessarily best practice, but you'll see it time and time again, unfortunately. So there's three different types of antibiotic therapy. So we have empiric, definitive, and prophylactic. So empiric therapy refers to treatment of an infectious agent before we have actually had information reported or obtained from a culture. Definitive therapy, that's the way we want to do it. We've identified it with a culture and we're going to select the appropriate antibiotic or antimicrobial therapy related to that specific organism or pathogen. Okay. Prophylactic therapies, we do commonly use these, especially for people with susceptible immune systems, and this is just treatment with antibiotics to prevent an infection, if they're having some sort of procedure done. And I can tell you specifically in my practice that I've seen this before catheterizations are completed for people that are extremely susceptible hosts. Okay, so that's something common. Same with dental surgeries. I'm not sure if you guys have ever experienced that, but sometimes a dentist will prescribe, a broad spectrum antibiotic before dental surgery is performed to prevent you from contracting any infectious agents while your immune system is compromised for that surgery. So very common with antibiotic therapy, we have to be cognizant of allergic reactions. So some of our very most common are antimicrobial agents in which people have allergies are our penicillins and our sulfonamides. And, always have to be careful when administering antibiotics if they don't have an existing allergy, that we're monitoring for those allergic reactions that can quickly turn into anaphylaxis if not responded to appropriately. So the most common severe reactions that we would see in these agents would be difficulty breathing, rash over the entire body, the hives rash, that marbling look on the skin, and also gastrointestinal intolerance. So a very common side effect of antimicrobials, they mess with the normal gut flora in the intestinal tract. So you will have diarrhea, things like this, but we want to know and monitor if that's getting beyond, the normal expected effect. And also to keep in mind and to tell your patients, very specific antimicrobials can diminish the effect of oral contraceptives for females. So that's always something that you want to be mentioning to those of childbearing years that may be taking oral contraceptives. So how do antimicrobials do their job, or antibiotics? So there's a few different ways. Essentially, we're manipulating the natural systems of the bacterium themselves so that we can destroy them. Okay, so that includes, messing with their cell wall, interfering with their ability to make proteins, inhibiting their ability to make DNA so that they can replicate themselves, and also acting to disrupt specific metabolic reactions within the bacterium itself. Okay. So different actions of antibiotics, we have our bactericidal, okay, very similar to what we were discussing when we're talking disinfectants and antiseptics, okay. So bactericidal, meaning they kill the bacterium, okay, and then bacteriostatic, meaning we're only inhibiting growth. So we're not actually killing them, but we're eventually leading to their death because they're unable to multiply, okay. So eventually the life cycle of the cell will end and those unable to multiply will die, but we're not actively killing these bacterium. So let's take a look at sulfonamides. So usually these guys you find combined with other antibiotic compounds. So some of the antibiotics you might see are definitely the sulfatrim. Okay, so we'll give that a little underline here. So our sulfatrim, our Septras, okay, and these are common antibiotics. So how do these guys work? So these guys are bacteriostatic, okay, bacteriostatic. They're preventing synthesis specifically of folic acid, which is actually required for DNA replication in bacterium. They do not affect humans, okay, so that's a really good indication for their use. And they only affect organisms that synthesize folic acid as opposed to absorb it from the environment. So you will see mutation of certain antimicrobials or bacterium that instead of creating their own folic acid, they start to absorb it from the environment as opposed, so that the sulfonamides don't actually have a therapeutic effect on them anymore. So indicated use. So these guys are useful against both gram-positive and gram-negative bacteria, and that I don't expect you to know the difference between a gram-positive and a gram-negative bacterium, only that there are two types, and certain antimicrobials are good against both, certain are only good against one or the other. Obviously, if they're effective against both, that broadens their therapeutic value, makes them more broad spectrum as opposed to narrow. Okay, so these guys, usually we're using them to treat urinary tract infections. There's a few different bacterium listed there. I don't expect you to remember these guys. But of course, our Streptococcus aureus comes again here, okay, and I'm sure you guys have all heard of the E. coli. E. coli. So there's also different types of pneumonia that it will treat, and upper respiratory tract infection. So now let's talk about our beta-lactam antibiotics. Okay, so these guys are our penicillins, our cephalosporins, carbapines, and monobactrams. So as you can see at the side here, this lovely little image is a beta-lactam ring. And as we'll talk more about penicillins, you will see that this beta-lactam ring is a critical component of their molecular structure. So there's different types of penicillins. We have natural penicillins, okay? We also have a couple of penicillinase-resistant penicillins. So penicillinase is an enzyme that breaks down penicillins. And then we have our aminopenicillins. Mechanisms of action of the penicillin. So penicillin specifically inhibits synthesis of the cell wall of the bacterium. Obviously a critical component for protection from the environment, to keep things that the cell doesn't want out, and obviously to have it form fully and divide. So once these penicillins inhibit this process, normal cell wall synthesis is disrupted. So cell walls are created by a molecule called peptidoglycan, and obviously if we're inhibiting that process of that being created, then there's no cell wall synthesis, and then our bacterial cell will die from cell lysis. So because we are unable to complete the form and structure of the cell wall, we have water rushing in, we have all kinds of our little organelles rushing out, and the cell will die. They do not kill other cells in the body. Obviously, if antimicrobials are effective against humans, they're not so effective for humans. Okay. So again, here's our chemical structure of the penicillin. Our beta-lactam ring, okay, is right there. And that's going to become more important when we get over into our ESBLs. Okay, that'll come into play. So indicated uses for penicillins, we're looking for treatment of infections of susceptible bacteria such as gram-positive, strep, enterococcus, and staphylococcus. So typically we would want a culture to tell us whether or not it's gram-positive, gram-negative, and if it's susceptible to penicillin. Adverse effects with penicillins. We have a lot of allergic reactions to the penicillins. Penicillin is one of the first antimicrobial agents to be discovered, and it is used very commonly. So allergic reactions can occur, and they have in 0.7 to 4% of treatment individuals treated. So that can manifest itself very badly, and if you are allergic to penicillin, then you're more likely to be allergic to other beta-lactam antibiotics because they carry that same organic chemical component. So sometimes people have what's called a sensitivity as opposed to a full-blown allergy. So those sensitivities can come as, just a little bit of discomfort or something like that. But if you do have a history of your throat swelling or hives, so a full systemic reaction, then you should not receive the penicillins or the cephalosporins that are in the same family. So let's go on to our cephalosporins. So these are somewhat synthetic antibiotics. They're related very similarly to our penicillins. They're bactericidal in nature, whereas our penicillins are bacteriostatic. Well, actually, no, sorry, I apologize. They're bactericidal as well because they inhibit cell wall synthesis and the cell will die. Broad spectrum are cephalosporins, and we're divided into groups based on what they affect. So we have several generations of the cephalosporins. So first generation, lots of gram-positive sensitivity. Poor gram-negative coverage, although, so an example of the first generation of cephalosporins is our Keflex. So that's that orange one. It's got a bit of smell. You've probably, if you've ever had antibiotics, you may have had that one. It's very common. Our second generation, better gram-positive coverage, improved gram-negative coverage on our first generation. By the time we get to our third generation, we have our most potent group against gram-negative bacterium so far, but we start to get a little less active against gram-positive bacterium. And by the fourth generation, we have a great broad-spectrum antibiotic, and it's really good against gram-positive bacteria, but it maintains that good gram-negative coverage as well. Okay, carbapenems. So broadest antibacterial action of any antibiotic. Okay, reserved for very complicated infections, and especially nosocomials. They have to be infused over a long period of time, and there's high risk of drug-induced seizure activity. And if you have been given the appropriate dose, this is much less likely. So although they're extremely effective as an antibacterial agent, there's quite significant side effects to human beings, okay, which is why they're reserved for only complicated infections. Monobactams. Okay, so these are another, we have astrenonam, synthetic beta-lactam antibiotic. So it's man-made, very effective against aerobic gram-negative bacteria, our E. coli, our Pseudomonas, okay, and it's bactericidal as well, so it's going to kill those bacterium. We only use it via parenteral administration route, and it's typically something you're going to see used in patients with cystic fibrosis. They have chronic pulmonary infections, so Pseudomonas infections that can put them in quite great risk, and so these antibiotics are quite effective. Macrolides, so we have our erythromycin, azithromycin, clarithromycin, and fidaxomicin. Okay, so what do these guys do? These guys specifically prevent protein synthesis within the bacterial cells. So they are bacteriostatic because they stop the cell from being able to create proteins. They will eventually die, but it's actually just halting natural processes within the cell. In high concentrations, although, it can be bactericidal. Indicated use, specifically strep infections, so Streptococcus pyogenes, mild to moderate upper and lower respiratory tract infections, spirochetal infections, so that's again that's a reflection back to those morphological shapes, spirochete. Okay, so specific bacterium that come in that shape that cause specific diseases are the bacterium responsible for syphilis and Lyme disease. Also chlamydia and gonorrhea. Tetracyclines. So these guys are semi-synthetic or can be more natural in their origin. They are obtained from culture of a specific type of bacterium called the Streptomyces. They are bacteriostatic, so they inhibit that bacterial growth, and they do that very similarly as the aforementioned antimicrobial with inhibiting protein synthesis. They stop essential function, and of course, eventually the bacterium will die. But they're unable to reproduce because of this inhibition. So specifically, they bind to calcium, magnesium, and aluminum ions. Okay, they can also be reduced by dairy products, antacids, and iron. Okay, those things can reduce the absorption of this antimicrobial. So that's why sometimes you see specific antibiotics given saying do not take with dairy products, that sort of thing. And these specific antimicrobials shouldn't be given to children or pregnant women or lactating women because they can actually cause staining of the enamel in teeth, and that's because of that binding ability to the calcium. So adverse effects, again, that affinity for calcium. So in children, it can cause permanent staining of the adult teeth. Pregnant women and nursing mothers, the same thing for the children specifically. And it can also stunt fetal skeletal development. So that's not something that we would recommend during pregnancy. Okay, so which does the nurse identify as being a concern for patients receiving tetracycline? Okay, and of course, do not administer with dairy products. Okay. So, with antimicrobials, so important before beginning therapy to assess for drug allergies, okay? Be sure to obtain a thorough health history, including immune status, right? Because we need to know those things. Assess conditions that may be contraindications. So always be wary of which antibiotics have contraindications and what they are so that you can ask the right questions before administering these medications. Of course, that prescription is coming from the physician. Also, drug interactions may occur, and we should always instruct your patients to take antibiotics exactly as prescribed and for the duration prescribed, because if they do stop taking that medication, it can lead to antimicrobial resistance, okay? And always watching for signs and symptoms of the worsening of that infection, okay? Okay, we're completing an admission assessment. The patient reports being allergic to sulfas. What does the nurse do? Okay, and our correct answer, C, right? Because despite what type of antimicrobial agent it is, we want to know exactly what that allergic response is so that we can tell if it's a sensitivity or if it's a full immune response. Okay, so let's continue. Okay, multi-drug resistant organisms. So these are our nosocomial infections, and they are resistant to one or perhaps more than one class of antimicrobial drugs. So we have our methicillin-resistant Streptococcus aureus, okay, our MRSA, vancomycin-resistant Enterococcus, VRE, and also organisms producing extended-spectrum beta-lactamases. So these are enzymes that break that beta-lactam ring and render penicillins and their counterparts completely useless. Okay, so MRSA. The threat is from MRSA, sadly and frighteningly, is that it's become resistant to many antibiotics that are currently available. And it's no longer only seen in the acute care environment. We see it very commonly in the community setting. And approximately 50% of staph infections in the community involve our MRSAs. Okay, so not only is it more prevalent than ever before, but we can't treat it very well with antimicrobial agents. So then we have our VRE. So typically this manifests as a urinary tract infection, not always. But we do see newer antibiotics that have been synthesized that can treat not only VRE, but also MRSA. So it's kind of the ongoing struggle, right? We find resistant organisms that we can't treat with current antimicrobial therapies, and so we actively pursue alternative ways to develop new antimicrobials to treat these infections before they become out of our control. And then we have our ESBLs. So these guys are resistant to any beta-lactam antibiotics, okay? So typically we can only treat them with carbapenems or quinolones. So if resistant, some even are resistant to carbapenems, so that's a little frightening because it seems like no matter how hard we try to find something to treat these infections, they start to mutate and then they become resistant to our new antimicrobials. So let's talk aminoglycosides. So these guys are a different type of antimicrobial, okay? There's several routes available to administer, but typically they're given orally, or sorry, they're not given orally because when given orally, they're not absorbed very well. When they are given parenterally, they're very potent and they can have very serious toxicity. So they are bactericidal, and they do this through preventing protein synthesis. They do kill mostly gram-negative bacterium, but some gram-positive as well. Indicated uses include gram-negative bacterium such as Pseudomonas, E. coli, okay? Typically they're used in combination with alternative antibiotics because they produce what's called a synergistic effect, meaning that they both produce their own therapeutic effect and together they work together to provide an even more potent effect. And they can be used for certain gram-positive infections that are resistant to other antibiotics, okay? So Enterococcus, Streptococcus aureus, bacterial endocarditis, which is usually, again, streptococcal in origin. Serious toxicities, so aminoglycosides can cause nephrotoxicity or kidney damage, and autotoxicity, which is auditory impairment or deafness. And so we need to monitor them very closely to prevent these irreversible toxicities from occurring. And you want that minimum inhibitory concentration. So what that refers to is the minimum concentration available to inhibit antimicrobials appropriately. You don't want to exceed that level because you want to be causing a therapeutic effect with the absolute minimum amount of medication required so as not to cause toxicity. So let's talk quinolones. Okay, so they're also called fluoroquinolones. They have excellent oral absorption, with the exception of one type, which I don't expect you to know. Okay, so we won't worry about this guy. Absorption reduced by antacids, calcium, magnesium, iron, and they're effective against gram-negative and some gram-positive organisms. So these guys, we have Cipro, okay, ciprofloxacin, norfloxacin, hydrochloride, levofloxacin, and moxifloxacin. Okay, you're going to see these guys quite commonly. Mechanism of action, they disrupt the DNA in the bacterium and cause the cell to die. They do not have any effect on human DNA, otherwise we wouldn't be able to administer them to human beings. They're indicated for gram-positive and gram-negative bacterial infections. You can have complicated UTIs, respiratory bone and joint infections, GI, and skin infections. Cipro and Levo are both oral and injectable. So a few miscellaneous guys that don't really fall into one of these lovely categories. Metronidazole, or Flagyl. So this is a very strong antibiotic, typically given for abdominal and gynecological infections, or proteazoal infections. Okay, so that's our fungi. There are definitely a lot of drug interactions, so it's typically reserved for people in emergency situations or very necessary situations. It is a common treatment for C. difficile. However, as we've discussed, I believe, in class, are we treating C. difficile with antibiotics or antimicrobials and causing more harm than good? Destroying that normal gut flora, and then, we only significantly increase the amount of rushing of digested material through the gut. And then we talked also about new research that speaks of transplanting gut flora between a healthy individual and an ill individual with C. difficile and seeing the benefit of that. So just something to keep in mind. Miscellaneous antibiotics continued. So we also have our vancomycin hydrochloride. So very important, hint, hint, nudge, nudge, to keep in mind with vancomycin. We can have red man syndrome. Okay, and typically this occurs when we infuse too quickly. Okay, so what it manifests itself as is flushing, itching of the head, neck, face, and upper trunk. Essentially, it blocks neuromusculature, and it can have negative effects as well on neuromuscular blockers. We should always infuse vancomycin over 60 minutes, and that prevents this rapid change in blood pressure, which may cause hypotensive effects, but can also cause this flushing of the skin that you see, this red man syndrome. So, nitrofurantoin. So this is our macrobids. Okay, you also, if you haven't been on macrobid before, you'll give a lot of macrobid in your career. Primarily used for UTI. Okay, so they can affect the kidney, so it's important to make sure that if you are administering them that you've monitored or screened for kidney dysfunction. So it specifically concentrates in the urine, which is why it's so effective against urinary tract infections, but it can cause hepatotoxicity or liver toxicity. Very, very rare, but something to be aware of. So, another question. A 58-year-old man is receiving vancomycin as part of the treatment for a severe bone infection. After the infusion, he begins to experience itching and flushing of the neck, face, and upper body. He does not report chills or difficulty breathing. So what do you suspect is going on? Okay. So, as we discussed, he's had his dose of vancomycin going a little too quickly, and he's getting a little bit of red mist. Okay. So Red man syndrome, again, occurring after infusion of vancomycin. Just that same characteristic flushing of the head, face, neck, and upper trunk area. It can be alleviated by slowing the rate of infusion, okay? So at least 60 minutes or an hour, and it's bothersome, but usually not harmful, okay? But keep in mind, if you're rapidly infusing vancomycin, you can cause hypotension. So of course, before beginning therapy, we're assessing allergies, renal function, liver function, and cardiac function. Always get a thorough patient history. Assess for conditions that may cause contraindications, potential reactions. It's also essential to obtain cultures from sites before beginning antimicrobial therapy. Okay? And instructing our patients to take antimicrobials exactly as prescribed, for the exact length of time prescribed, and do not stop taking the medication when they feel better, because then we're leaving behind the resistant guys that perhaps didn't get knocked out with that first round of antibiotic, and they'll only pass that resistance on to their next generation. So always monitoring for therapeutic effect, because if we're not causing that therapeutic effect, what's the point? So we want to see improvements of the signs and symptoms of the infection. We want to see a return to normal for their vital signs. We don't want to see fever, and we don't want to see diarrhea, low blood pressure. Negative culture and sensitivity results. So after we finish a round of antimicrobials or antibiotics, we will typically look to recapture another urine or blood culture, but it can't be done immediately after the antimicrobials are finished because they will still be in the system and they will skew the results. So typically a couple days afterwards, and that's designated by the healthcare provider. We don't want to see fever, we don't want to see lethargy, we don't want to see purulent drainage, that yucky smelling, multicolored stuff, and we don't want to see that red, angry, warm to touch skin. Always observing and monitoring for adverse reactions. Okay, so that's our 32-minute lecture on antimicrobials. I hope you found it informative. Thank you.